I like to start preparing the graft before the patient's asleep. This is a tibialis tendon allograft. This particular one measures 25 centimeters in length, and at its thickest part here is about a centimeter in width. So what we like to do is we want to divide it in its mid portion. Now, David Caborn has done extensive studies on pull-out to failure of multiple grafts and has shown that if you do a baseball stitch of either fiber wire or Ethibond, and fiber wire is better because of its increased strength, for the length of where your interference screw is going to be, that you will increase your pull-out to failure by somewhere between 20 and 30%. So that the apex of this will end up in the femoral socket, and I know my screw's 20 millimeters, so I'm going to run a baseball stitch 20 millimeters down here, 20 millimeters down here. I'm not going to sew them together as one bundle because we're going to be one of these is going to be the posterolateral ACL bundle, and the other is going to be the anteromedial. That part will be in the femoral socket, and the interference screw is going to go between them to separate them so that we create the bundled effect. Then I'm just going to tie this off. And you want to have, at the apex of this, or what engineers call the bite end, you want to have suture free, so you don't have some big glob of suture that will block this from going into the, getting started in the socket. So now we know that the native ACL averages 28 millimeters in length. So that blue line is going to be at the femoral intra-articular orifice. So what's going to be in the knee and become the ACL is that 3 centimeter distance. So we got the femoral side. Now we've got to deal with the tibial side. Then when we're all done, we need to size the diameter of this construct once it's put together, because that's going to determine the diameter of the tunnels we drill. And usually one of these is slightly larger in diameter than the other. I want the larger of the two to be the posterolateral bundle. Prior literature has shown us that the lockment and the pivot shift largely resides in the posterolateral bundle. I got 20 millimeters of suturization on each limb that's going to go in the femoral socket. I have a 3 centimeter separation of soft tissue that's going to become my intra-articular ACL double bundle. Then I've got another 2 centimeters that's going to reside in the upper aspect of the tibial tunnel, and our retro screw is going to go backwards against that. The last thing we need to do is get fiber wire purchase on the end of this so we can tension the graft. So now we want to size our diameter so that we can know what size tunnels to make, because we want this as tight as possible to be able to get the graft in. So here's a 10. So 10's tight. That's what we're going to go with. We want to pre-tension our graft because we can get about 2 millimeters of creep out of that graft, and I want that to happen before I put it into the knee. So I want to stretch this at 15 pounds for a half an hour. This is spring-loaded, and it's at 15 pounds axial pressure. And you'll notice when we come back a half an hour later, it'll be down to like 10 pounds because it's stretched 2 millimeters. I want that to happen before I put the graft in. So let's look over here. His ligament mucosa has been all stretched out, and there's his ACL injury. So let's get rid of all of that. We want to assess what this guy's native notch width is. If it's 15 millimeters or so, then you don't really need to do a notchplasty. Now I want to look right down on the intercondylar floor because I really want to see the true insertion. This is where we're going to be putting the retro screw in. And I need to know, there's the lateral meniscus, the anterior edge. I don't want to take that off. I want to stay medial here. And that pit between, I want to be in this pit between the spines when I come in, and I want to see it. And then I want to reference the anterior aspect of the PCL to know where my pin's going to come out about right there. So now it's time to make the tibial tunnel. So the sartorius is coming just like that. I want to make a small incision just on the superior surface of the pes. Right there. The MCL is right here. There's the sartorius, so I want my tunnel to be right there. And remember, I want a 10 millimeter tunnel, so I'm going to expose subparasteally. And I'm just going to make a little nick in the cortex so that my pin, when I start it, doesn't wander. This is our tibial placement guide that references off the PCL. Pretend my finger's the PCL. It comes in from the medial portal, references off, and it places a pin in the crosshairs here, 7 to 8 millimeters anterior to the PCL. So now this needs to go in the medial portal, and then I want my pin to come out equal distant between the apex of the medial intercondylar tibial spine and the lateral one. I want to be dead in the middle, and I want to reference off the PCL. So I want to be kind of like that. Because the portal's above the level of the joint line, outside on this it'll usually read about 70 degrees. Perfect. So we're right kind of where we want to be here. So that's pretty darn close. It may be a half a millimeter more medial than lateral, but I can correct that as I go. The distance between here and the front of the PCL is about 7 or 8 millimeters. So if I bring this up an extension right now, and the things that's not going to roof impinge. And you want to use a straight drill bit, not an acorn drill bit. Posterior. There you go. And you can see I'm dead center between the spines. Okay, now outside here, the periosteum on the outside of this tibial tunnel is going to want to go inside the tunnel, and it's going to block getting your graft up there. When I go to push my graft up in there, now it can freely go in here. So there's my tibial tunnel, and I want to go make my femoral tunnel now. So let's have the offset guide. Now, if we look at this, 12 o'clock's there, 9 o'clock's there. And I would say maybe 3 or 4 years ago, people were making their grafts more vertical. Okay? That gives you really, really good, as you get more vertical, you get good AP stability from your single bundle reconstruction. But you do it at the expense of rotational control. But if you come all the way down here, like at 9 o'clock, you'll have great rotational control, but you'll lose anterior-posterior control. The whole concept of the double bundle reconstruction is to get both. So I want to come kind of halfway between 9 and 12. And you'll understand, I haven't done a notchplasty, so true 9 o'clock is there, and true 12 o'clock is there. If I took this notch back 5 millimeters over here, then what you thought was 10 o'clock really becomes 11 o'clock in your mind, and you can get confused. That's why I don't like to do notchplasties unless I have to. So I want to go over the top there, and I want to cheat a little about right there. Now I'm going to make a femoral socket. So now what I want to do is just make a little footprint. See, and I can see I got back wall, and I'm going to be fine. Okay? So now I'm going to go in 3 centimeters, which is going to be about right there. Here's our joint line. 12 o'clock's right there. 11 o'clock's there. 10:30 is here. I want to now notch this so that I got an anterior medial bundle here, and then my posterior lateral bundle will be way down there. It's 7 o'clock and 1 o'clock within your tunnel for the 2 bundles. This tool allows you, by advancing it forward, that's a 5 millimeter notch that it will create. Now you can really see the geometry of this. I just want to round this off a little bit, because this guy has such hard bone, I don't really want an abrasive surface here. I'm going to look at this socket from the medial portal. The distance between there and there is 21 millimeters, and the socket's in the center. So we want to go up here, past the central tibial tunnel, past the PCL, in the center of the femoral socket, and out the distal lateral thigh. This thing's been, for 35 minutes, has been stretched at, or 15, we started out at 15 pounds longitudinal distractive force. Now this thing reads 12 pounds. And what's really happened is this is lengthened by 3 millimeters. So what I'm going to do is I'm just going to put a line on that one. So I want that to be the posterior lateral bundle. So we want to go up past the PCL. Okay, now the way this is going up, the one I want to be posterior lateral is oriented like anterior medial. So I want to turn this like that. Pull, pull, pull. Good. And there you go. Stop. So now they're oriented. So now we want to put our femoral sided screw in first. Our screw is actually going to come into the joint from this medial portal, and this prevents screw hang up through the fat pad, which is over there. This is a retro screwdriver. It's got a hex sort of orientation here. It's fully cannulated, And it has a number 2 fiber wire threaded from the back end up through its full cannulation past the tip. And I like to have about 6 inches of suture sticking out the working end of it. Now, what I will do is I want to bring this screwdriver up through the tunnel anterior to the graft to about here. And then if I withdraw it, it leaves a loop of suture. I want to come in through my slotted cannula and pick that suture up. So now all I'm going to do is tie an interference knot so that now if I pull on this, that knot will abut the tip of the screw and it's got nowhere else to go but go into the joint backwards. Now I'm just going to pull on the suture on the back of this and it'll pull the screw onto the screwdriver. How hard was that? Now if I screw the screw in right now, then the suture will be trapped in there. So what I'm going to do is take the suture out now by pulling out here. And so what I want to do is bring this anteromedial bundle up a little bit like that so that I can get the screwdriver between the bundles. So now I'm going to advance the screw up until the screw head is buried inside the orifice by about 1 millimeter. And you can hear the noise it makes. And that's that noise you want to hear. Now I'm going to pull the screwdriver out. When I put this retro screw in, I want this posterior bundle to be more like over there. That's more anatomic. I want to put my screw lateral and anteriorly. Okay, now I'm going to take the screwdriver and I want to come up anterolateral to all this stuff right there. This time I'm using this little nitinol wire because I've already got my retro screws for the tibia preloaded in my cannula. So now what I need to do is pull this wire. Then I'm going to take this obturator behind the screw and just push it in. Now it's in the joint. Then I'm going to pull that like that. Now I'm going to just turn the screwdriver down just a little bit, and then there we are. Now, to maintain the screw on this so that I can screw backwards, there are these 2 little posts, and I'm going to do figure of 8 around them. And then I need to make sure that my posterior bundle is going behind there. Now, you're pulling on both bundles hard. I want you to range the knee. Flex. Good. Extend. Good. Okay, right about there, mid-range, right there. I'm screwing backwards, which is counterclockwise. And so we're going to screw it in until the screw head is flush with the intercondylar floor. And look where the posterior bundle is. It's directly posterior where you want, and you want then the other bundles anteromedially. Now each one of those bundles is 8 millimeters in diameter. Okay, so that's about exactly what we want right there. Okay, now we're going to release the suture out here. And I'll pull that out. And there's our completed reconstruction. Now you notice we don't have impingement on the lateral wall like you're used to with a posterior bundle. See the anterior bundle relax in extension? There's no roof impingement. And then as I come in flexion, right there they're equally tensioned, which is mid-range flexion. And now as I come in full flexion here, the posterior bundles relax somewhat. But you'll notice I have rotational control here. In flexion, the anterior band is tensioned well there. Now, and the posterior bundle is also, it's slightly loose. Now extend, stop there. We're in about 65 flexion. These are both tensioned well there. Come in extension a little bit more. They're both well tensioned. Now as we come, we're only in 20 degrees of flexion now. The anterior band's relaxed just like a normal ACL. There's about a millimeter of play. But look at this one. The posterior bundle's tensioned well there. Now come in full extension. Full extension. Good, right there. And then our posterior bundle, it's a tension well there. We've done, where there are preliminary studies going on now where we do, in cadaveric reconstructions, we're putting mini Hall effect strain gauges on the native ACL posterior bundle as well as these double bundle reconstructions. We're getting the same sort of reciprocal tension handoff and flexion extension with these reconstructions. But you see, we've got what Savio Wu is talking about rotational control here at 9 o'clock, and you see we've got collagen from 10 o'clock to 12 o'clock. So we've accomplished both goals. He has absolutely no lockman. 20, he's rock hard stable. 60, he's rock hard stable. And the beauty of this case is at 90, he's got no drawer. You'll never get that with a single bundle reconstruction.